Hi everyone, welcome here with us today. We have a webinar in 1 hour in the topic of from long-term costs to policy change, a comprehensive view on chronic pain. Welcome here. I am Zsófia Nagy. I will be today here with you, and here will be our presenters, Odin, Patrice, and Johan together. I am a research project assistant from European Pain Federation, and you can find all the attachments and files which will be helpful for today in the meeting invitation. So there were some articles and resources which will be mentioned here, and you can search for them. Thank you so much for being here. First, we would start with a short introduction. I think, Patrice, you could start it.
Thank you. First of all, thank you so much for organizing this webinar, and thank you all of you for being here. It's really a pleasure, but also very important. My name is Patrice Forget. I'm a professor of anesthesia and pain medicine in Aberdeen in the UK. And I'm also the chair of the Social Impact of Pain platform, and I will expand a little bit on that later. Thank you.
Thank you, Patrice, and welcome. Odin, would you like to continue?
Yes. Hello, my name is Audun Stubhaug. I'm a professor of anesthesiology and pain medicine in Oslo University Hospital, and also head of a multidisciplinary pain unit.
Thank you. Johan.
Yeah, sorry. My name is Johan Stansen. I'm a consultant at the CRO and also researcher at the University of Oslo.
Thank you so much for being with us. So today we have 1 hour for this session, and don't forget that we have a Q&A session and part in the Zoom platform, so you can ask questions during the presentations, and in the end we will leave some time to answer your questions. And right now I will give you the floor, Johan and Odin, to start your presentation. Thank you.
Thank you. I'm now sharing my screen. I hope it's everyone can see it. So we'll here present our paper, The Cost of Chronic Pain, Long-Term Estimates, that was recently published in the European Journal of Pain. These are our disclosures from myself and our co-authors. And let's just, I guess, dive right into it with the background first. I think all of you are well aware of the kind of what pain is and chronic pain and its kind of overall burden on society, and particularly how it impacts many aspects of life, including work and functional ability, quality of life, but also physical, mental, and social well-being. And when we reviewed the literature a couple of years ago before we started the project, we saw that there has been a lot of studies on the costs and economic burden of chronic pain. But there was a range of different methodologies applied in the literature before, particularly on identifying patients with or individuals with chronic pain, relying everything from survey-based and self-reporting to diagnostic codes like ICD-10 codes. There was a range of cost categories included, not only healthcare costs, but also work absences due to sick leave or disability. A lot of different type of data sources being used, from survey data to registry-based data. And also some studies did and did not do comparisons to the general population as well as a comparison group. But there was also a limitation in these set of studies. Many of them were relying on small sample sizes. Some used survey reporting instead of administrative data on resource use, for instance. Some also lacked cost categories related to work absences. Some also lacked comparisons to matched populations. And also, on the last point here, many also relied on diagnosis codes to identify those with chronic pain. So that's what we kind of saw in the literature beforehand. And our aim with this paper was to quantify the economic burden of chronic pain, and thereby provide policymakers and others more information and better information on to make more better informed decisions when prioritizing finite healthcare resources. So our study, and the aim of the study was then to kind of address some of the limitations and things we've seen in the literature before by identifying individuals that self-report to have chronic pain instead of using diagnostic codes, but then also doing that in a large population setting with a lot of individuals, then using survey data with high participation rate, and also link the data and individuals with data on administrative use of resources. So resource use based on administrative data. And then also compare those who self-report chronic pain to have chronic pain to those who do not report to have chronic pain. So the study design and what we've done here is essentially our starting point was two Norwegian population health studies, Hunt and Tromsø, which are two geographical areas in Norway. They are conducting these health studies, and they've done it for many years. And we started with the health studies, Hunt 3 and Tromsø 6, conducted between 2006 and 2008. And in there, they have questions on chronic pain, which we use. And then for all individuals in these two health surveys, we link a lot of, or a set of administrative data sets that are available in Norway to essentially then calculate direct healthcare costs and indirect work absence costs due to sick leave and disability. And these outcomes, healthcare costs and work absence costs, we calculate them for the years 2010 to 2016. So the list of data sources are listed here on the right on the slide. So a bit more detail on what we actually did with the study population. So we start with everyone who participated in these two health surveys, Hunt 3 and Tromsø 6. And they have a question in there on pain, on chronic pain. In Hunt 3, the specific question was, do you have physical pain now that has lasted more than 6 months? Yes, no. And in Tromsø 6, the question was, do you have persistent or recurring pain that has lasted for 3 months or more? Yes, no. And then everyone who answered yes to these two questions, they were put into the case group, those who we define as self-reported chronic pain. And then we put everyone who answered no into the comparison group, potential comparison group, or matched comparison group. And then we match the cases and those who answered no on birth year, 1 plus minus 1 year on the birth year, sex and health study. So it's a very kind of simple matching approach just to kind of adjust for some very basic covariates. I'll come back to reasons why we haven't included more variables to account for in the discussion part, but that's what we do. We compare those with and without self-reported chronic pain, adjusted for these very core covariates. The specific costs that we include are listed here. In terms of healthcare costs, what we've included are in and outpatient hospital visits. So that's specialty care visits. We use DRG codes to cost. Then we also have visits to a chiropractor, a psychiatrist, and physiotherapist as well, where we apply the unit cost to each visit. We also have visits to GPs and private contract specialists, so outpatient specialists outside of the hospital, where we also apply unit cost. We also have rehabilitation center visits where we use DRG codes to cost. And then we also use the prescription medication register to include costs for prescription medications. There we use the pharmacy retail price. So all of these categories grouped together are what we then say are the direct healthcare costs. And then we have the work absence cost, productivity losses, indirect costs. It's a lot of kind of different names for the same thing here, but that essentially means sick leave and disability episodes. So in Norway, you get sick pay and also early retirement due to disability. And all of those time periods where you are on sick leave and receive sick pay and on disability pension, that's recorded into an administrative register, and they are the dates and spells that we have access to and use in our cost estimation. And we use the so-called human capital approach to cost work absences, which are essentially that the cost of a day absent from work is equal to the national average wage in Norway. That's the costing approach. So these are the cost categories that we've included in the study. So let's dive into the results. These are some characteristics of the study population at the time of in 2008 when they've answered the survey. 36% of the total sample of all participants in these two surveys, there were approximately 60,000 in total. 36% of them approximately answered yes to this chronic pain question. And then we've rematched the two samples such that we are left with almost 23,000 in each group. So compared to previous studies on self-reported pain, that's a pretty substantial amount of individuals that we do have data on that self-report their chronic pain. I guess unsurprisingly, there are more females in the self-reported chronic pain group. The mean age at the survey time was 56. And in terms of socioeconomics, so employment and household income, generally we see that those who self-report to have chronic pain have lower incomes and lower employment rates than those who do not have chronic pain. They also have slightly lower levels of education as well. And we also have their levels of sick leave and disability pension at the time of the survey as well, and they do also have more sick leaves and disability as well at the time of these surveys. So I guess this is a picture that is kind of expected, that more females and a lower socioeconomic status. We also have some data on quality of life and behavioral variables. Those with chronic pain, and they smoke a bit less than those without chronic pain. They are a bit less physically active, and they also drink a bit less alcohol as well. So that's the kind of summary of these variables. In terms of medication and use of medications, those with chronic pain, they do receive or dispense more prescription drugs, pain prescription drugs, both NSAIDs and opioids. They also report to take more over-the-counter pain medication as well. So this is kind of unsurprising, right? These individuals are in pain and do get medications for it, both prescription and over-the-counter. By the Charles-Quant comorbidity index, we also see that those with chronic pain also have slightly more comorbidities than those without chronic pain as well. So keep in mind that we've not adjusted for any comorbidities there, right? So that's one of the, I guess, features of the study population here, that those with chronic pain also report to have more comorbidities. In a subset of individuals, those from Tromsø, they also answer a question on quality of life through EQ5D. And unsurprisingly, I guess, they do report to have lower quality of life. So if you see here on the bottom, those with chronic pain have 0.69 on the EQ5D index score scale, compared to 0.90 on those without chronic pain. And the main driver for this difference in quality of life are in the pain and discomfort scale, where a substantial amount of individuals in the chronic pain group report to have moderate to severe problems. So that's kind of the main difference between the two groups. But we do also see that on the other dimensions, on anxiety and depression, mobility, self-care, and usual activities, those with chronic pain also report higher rates of moderate problems on those dimensions. So this is, I guess, the main figure in terms of the healthcare costs. These are costs per individual over time from 2010 to 2016. The top line here, they are the ones with chronic pain, and the bottom line here is those without chronic pain. And then the numbers in between here is the difference in average cost per individual between these two groups. And we do see that essentially in every year from 2010 to 2016, the average difference in healthcare costs is 1,500 euros on average. And that's pretty consistent between all of these years. But the relative difference between the two groups decreased a little bit over time. So you see here that in 2010, the difference was 70%, but in 2016, the difference was 49%. But the absolute number, the absolute cost number is pretty stable. Please note that these numbers are inflation adjusted, so these are 2020 euros. But I think it's pretty remarkable in a way that these individuals are identified in 2008 based on a single question, and still in 2016, 8 years here later, we do still see quite substantial differences in terms of healthcare costs between these two groups. So 1,500 euro difference in healthcare costs. Let's look at productivity losses, so work absence. These are numbers for only those in working age in each year, so that's below 64 years of age. Again, the top line is those with chronic pain, bottom line, those without. And you will see here in 2016 that the difference is 11,000 euros. And the relative difference between these two groups actually increased over time. So it was 117% difference in 2010 and 145% difference in 2016. So it's an increasing cost trend here in terms of both absolute costs from 12,000 to 19,000, but also on a relative increase in that difference over time as well. Keep in mind, this is only those in working age. This is the same figure, just divided by everyone in the sample. So the essentially denominator is larger because we include those outside of working age as well. And we do see the same picture. And I guess the headline number here is that this 6,700 euro difference in productivity losses in the year of 2016. But again, we do see that it's pretty consistent that those with chronic pain in 2008 do still report higher work absences 8 years later. So this is only, we've not looked at kind of follow-up questions on chronic pain. It's all based on that single question in 2008. But we do still see these large differences even 8 years later. To summarize these numbers, the difference in 2016 in total for everyone per individual on average was 8,200 euros, divided by almost 1,500 euros in healthcare costs and 6,700 euros in productivity losses. And then in the paper, we do this back of the envelope calculation as well to kind of aggregate these numbers. As I said, 36% of the sample in Hunter and Tromsø answered yes to this question. If you extrapolate that to the entire Norwegian population in 2016, we get 1.4 million Norwegians that could potentially report to have chronic pain in 2016. If you multiply 1.4 million individuals with 8,000 euros, we'll get 12 billion euros. The Norwegian GDP in 2016 was 335, which ends up, which means that the difference between those with and without chronic pain was 4% of GDP in 2016. Obviously, this is kind of a back of the envelope calculation and extrapolations, but it says something about the scale of the economic burden of chronic pain. One thing that's important to note here is that we essentially estimate economic burden associated with chronic pain. We did not seek to answer the economic burden due to chronic pain. Chronic pain is a very multifaceted condition, as you all know, with often many causes and unclear causes. And some of these cost differences can be due to actual pain conditions like musculoskeletal conditions or fractures or things like that. Some of them may just be associated to chronic pain, like diabetes, for instance, and some may be a result of the pain itself, like mental health issues and so on. So we've not tried to kind of control for a lot of these comorbidities and conditions that are associated or due to chronic pain, because we wanted to kind of tell the overall picture, because If we try to control for, say, diabetes and other conditions, we were afraid of running into issues of overmatching and actually kind of controlling away something that's of interest, because we know that the implications of chronic pain are very broad and have large ramifications. So that's why we are very careful here to say that these are costs associated with chronic pain and not necessarily due to the pain itself, right? So yeah, to conclude, we find that the societal costs associated with chronic pain may be as high as 4% of GDP in Norway. The society uses then a great deal of resources on these individuals, but we also do see that there's a disproportionate amount of kind of research funding, for instance, going into these conditions compared to the scale of the burden. And we do believe and hope that these estimates could serve as a basis for future discussions on healthcare use and prioritization, and the rehabilitation and quality of care and education of the public on the burden of pain. I'll leave it there, and thank you.
Thank you so much, Johan and Odin, for you too. Don't forget that we have a Q&A section, so you can put your questions there. I think we will listen now, Patrice, and then after Patrice's slideshow, we can have some time for the questions to answer. Thank you. So, Patrice, the floor is yours. You are muted, Patrice. Muted. Sorry. Okay.
Sorry for that, just needing to jump from Windows to Windows.
If you prefer, I can do
No,
this.
no, that's okay.
Perfect.
That's my
Perfect.
fault. I just wished not to accidentally interrupt fantastic Johan's presentation. I will just reopen then my slides. And so in the meantime, the goal of my presentation will be just to possibly immodestly inspire attendees to think about what can we do actually, and I will for that give a few examples uh, corresponding to what the social impact of pain platform has done till now, and what could be done with SIP, so partnering with SIP, or reflecting on that and maybe doing similar things. So it's definitely not to convince people that only SIP can do some work in the field, but it's also to say that documents, materials, tools, methods may be reused. So do not hesitate. I will come with 3 examples of activities, and there will be QR codes. So if people want to scan the QR code to have access to the materials, feel free to do that. So it's just to let them know that they can then prepare their phone or to take screenshots. These are my slides. Hopefully now you can see them and hear me well. Otherwise, feel free to let me know. I have already introduced myself. Just to add that initially trained with my French accent in Belgium as an anesthetist, a pain specialist, and then moving to the UK has been quite been an inspiring experience, because science is the same, but how to implement scientific findings can be very, very different. And all we know that in our environment, but that does mean that we can definitely learn from each other, but we also need in our different environment to come with specific data to be sure that that in our specific context, it does make sense. That's what SIP does at the European level, but also at the national level. SIP would be nowhere and wouldn't be existing first without patients. So that's my pleasure here to present you the team, and in particular Lisa Jutila, who's Pain Alliance Europe board member. Pain Alliance Europe is an umbrella organization representing more than 400,000 people living with pain, and then is the patient organization partner co-leading SIP. SIP is scientifically supported and co-led by EFIC, as you know, representing 20,000 healthcare professionals working in the field of pain in the 38 European countries and the chapter of the ISP. And the engine of SIP is on the slide. Angela Cano Palomares, Advocacy and Project Manager at EFIC, and Marta Batnica, Advocacy Project Officer. Without them, that wouldn't be possible as well. So thank you all of them for the input, but also for making this webinar possible. So concretely, what SIP is, that's then a multi-stakeholder platform. As I've said, that's important to have that kind of multi-stakeholder platform. So when thinking about going back to our decision makers, we definitely much stronger together. That helps raise awareness of pain, but also change pain policies. And I will show a couple of examples because we can actually make a difference by partnering, collaborating, and trying to open doors. We have sponsors, and thanks to the support of the industry, even though we try to diversify that as much as possible, but thanks to their support, all that is possible. First example of an activity, the SIP Book of Evidence. So feel free to scan the QR code. That's an example of an activity that we have created for individuals from a non-scientific background. So all the data we have heard before, and thanks Johan for presenting that, because these are extremely important data, but how can we disseminate that kind of information? And that's an example, the Book of Evidence, something we've done for making it readable, understandable by people without a scientific background, but starting from people experience and patient testimonies, but then later on having showing some good evidence to say that this is actually what people live with, but this is also the evidence at population level that may matter for a decision maker. So for encouraging them to actually take some actions for different pain conditions, knowing how common they are and how problematic they can be for people living with them. Of course, advocating for the biopsychosocial model, and I will expand a little bit on that later. But just to show you a few things that are in this book of evidence, it explains how chronic pain impacts quality of life, mental health, and the social impact of that, including the problem of social isolation and premature death that can be directly or indirectly related to pain conditions. 1 on 5 in Europe is impacted by chronic pain. That's an important aspect. And here I report a 4% of the GDP, which is an estimate, and it's pain-associated costs. Totally right, but that's a very important aspect. 4% of the GDP is just enormous. Europe cannot neglect that. We have to do something to better support these people and at a social level to try to lighten the load for making our society functioning better. Prevention. So you have also here the QR code. We have produced some documents. Prevention is key, definitely. It's not only about primary prevention only. Primary prevention, of course, if you can prevent pain or reduce the burden of pain when pain is still acute or in low-risk individuals, that's obviously important just to feel supported in our daily life, but also secondary prevention, and especially when chronic pain becomes more problematic, installed, and to be sure that people can better live with pain, even if it's there. That's also a question of health equity. Health equity is really problematic and particularly problematic in painful conditions, people with low socioeconomic status, marginalized community. Joanne has as well described that. These people are disproportionately affected, and anyway, financial health of people can be endangered when they experience the development or the chronification of a pain condition. So this is absolutely essential to try to better support these people. Here you have the SIP recommendations that are summarized, but in detail, you can go to the documents that are reachable with the QR code. Rapidly going there and to explain you the logic of that, raising awareness is definitely something important. That's one of the first activities that we have to consider when designing advocacy work, raising awareness and public health campaign. So targeting individuals, but also targeting the society to also improve the education of the entire community. We would like to promote structured exercise, education programs, not only the program itself for the program, but also for the process to be sure that people are supported by structured components in the system, but also by individuals interested in implementing that kind of program. So that's a complex dual approach, but an important perspective that's not just about exercising. Anyway, low-risk people, including any of us, need to move, and that's good to move, and that's good then to implement that to be sure that pain is prevented as much as possible. The third one is about implementing evidence-based standards for the management of acute and chronic pain, and to be sure that science is actually implemented. That's important also when we think about efficient programs. So we have to focus where the money is invested, and we have to inform our decision makers to let them know where the evidence is, to be sure that money is not wasted and that money is reallocated if better evidence is generated. Ensure early access to biopsychosocial rehab for high-risk individuals, because we know that just telling people that they have to move might not be realistic at some point of the development of chronic pain conditions. So biopsychosocial approaches for high-risk individuals is something we have to offer. That's a part of secondary prevention, but that's also part of the management of pain in general. We have to promote that, including for people wishing to continue to walk. That's the fifth one, workplace-based intervention, both for primary and secondary prevention, is essential. And for that, promoting cross-sector collaboration is also important to be sure that at the policy level, that's actually well recognized, making implementation easier. Not forgetting the seventh one, primary healthcare systems. Pain is primarily managed by non-pain specialists. So how to educate them, how to support them, how to manage some resources to be sure that pain as a chronic condition is also well addressed. And research obviously has to be promoted, because there is still so much to do, so much areas where level of evidence is not yet satisfactory. So that's where we have also to invest. Another example, and that's the last one, another QR code for an example of an activity that has been well promoted at the European level by SIP is ICD-11 recognition and thinking about the implementation. That can be also promoted at national levels and also at the local levels. In my research program, I have implemented ICD-11 as the terminology to be used for chronic pain recognition and documentation. That's also true in education programs. ICD is the global standard for diagnosing and coding health conditions. That's the classification of the WHO. The ICD version is the last one. That's very important because, in contrast with previous versions, it formally recognizes chronic pain as a condition in its own right. So it's not only a symptom, but it's also a condition. And you can easily imagine why patient and patient organization really consider that it's a priority. Otherwise, if pain is not documented, it simply doesn't exist. So we have thanks to previous data that have been presented, the chance, that was the word that I was looking for, the chance to have good data or better data now to raise awareness on the importance of pain, but we need better data in the future to be sure that the right actions are identified and that the right implementation process are ongoing. So here, if you want, there is also this publication, why do we need to implement the ICD-11? That's a publication where some efforts have been done to clarify and to motivate researchers and clinicians. Thank you very much indeed. I will stop here and let some place for questions and answers. Thank you so much.
Thank you. Thank you, Patrice. I hope everyone could see the slides, and also with about the QR codes what you shared. We also shared in the invitation, as I mentioned, the webinar invitation, the Sept book of evidence link, so you can have some access to it, and also for the article if it's needed. And thank you so much. We have some question. I think it leads us really far. Since most costs come from productivity losses, should we start focusing on work-based interventions instead of healthcare interventions only?
Maybe I can answer first as more of an economist, and then Audun maybe can take over as a clinician later on. But like, as an economist, I think the kind of ability to work is really important. Like, it is the backbone of our economy, that people work and contribute to the economy. So every day a person is not working, you know, there's a cost associated to that person cannot contribute to kind of GDP, right? That's a very kind of economist way of thinking, that we need more people just to contribute to GDP. But I think it's also important to know that, like, the ability to work and working is not only important for the broader economy. It's also like about self-worth and the kind of feeling of individuals themselves, kind of that they contribute and feel of meaning in life and things like that as well. So it's important not only from a societal perspective and, you know, looking at GDP, but also from the individual. I don't think it should be an instead of. I guess it should be both. That you should do both, but a broader focus to also look at work-based interventions. I think it's from an kind of economist point of view, it's an important point. I don't know if you have anything to add.
I fully support what Johan said here, but as a clinician, I would say that these data may support that we use a lot of resources, in particular on younger people who are out of work or maybe out of education due to pain, that this so it gives economic support to the idea to use a lot of resources. And as a clinician, when I meet a patient for the first time, a chronic pain patient, one of the aims of the consultation is to find goals for the treatment, future goals. And I do try not to focus on the pain. It's not about pain intensity. I try to make goals that are functional. So it could be in a young person, it could be to finish school, to finish education, to try to get a job that is more suitable than the ones I have now, or to come back into a job they've previously had, and in that with that kind of goals in a multidisciplinary clinic, you have to collaborate also often with the jobs, and you have to collaborate with administrative systems of work absence and so on. So I think yes to the question, we should concentrate on the workplace, but not only, but that is a part of a full treatment plan for a chronic pain patient. The workplace is a part of it. And we know, in fact, that white collar work leader positions, they can easily adapt a pain condition into their job, and they may not fall out of work so easily, while blue-collar work is more difficult, and people very easily fall out of the job when they have a pain condition. And those people will need more collaboration between us as clinicians, the GP, and the employer.
I usually can't agree more, and you have both of you addressed and answered very well the question. So I won't repeat that, but the key home message for me is that definitely at the society level, that's quite clear. It costs so much to the society, and at the individual level, investing in healthcare is likely to help the society to get more than what they invested for healthcare. So that's probably a bi-directional discussion where definitely need is there, but and the solution is partly there as well. So that's quite clear. A small complement to the answer is that there is a big move because we know what we can do, or maybe what we cannot do also, um, and the things that we may have to de-implement. That's another a discussion. But so in healthcare, what we can do, what we have to do, or what we are commissioned to do by decision makers and by politicians, that there is a significant move from the EU Commission to promote a competitivity and to promote activities that target specifically competitiveness at the European level, and to articulate better healthcare with competitiveness. We're not there for making, or we're not commissioned to improve the finances of the countries, but we have a role to help people to thrive. It costs even more to the individuals than to the society, but it costs to both. So we have a role there, and we cannot totally distinguish this role. We may have in the past, maybe, that's right, focused specifically on healthcare, not considering the social impact as we are doing now, but it's clearly something that, or where we can work hand in hand. So that's quite a consensual, but also clear and quite concrete move from our side, because if it comes from the European level, also a clear move from the EU Commission, but from all the countries, including the non-EU countries, is that there is a move to decentralize more, to delegate more the financement to the countries, or to different entities. So we have a role there to influence policies, to be sure that our decision makers, even at the local level, have the correct information to take the right decisions.
Thank you for the answers. So far, I haven't.
If I then may take the opportunity, because I had a burning questions for both Odin and Joanne. I didn't dare, because maybe that there was other question, and I'm certain that people are thinking about. But Odin and Joanne, to what extent do you think that that kind of methodology could be replicated in different countries? Maybe in different systems, maybe with slightly different questions. I'm thinking about, for instance, slightly different questions where the methodology should be adapted or not. But what about carers? What about other costs that we may not necessarily have an easy access to? That may be very different depending on countries to countries, because these people like carers may be differently supported. So that may be different but similar. What are your views and the easiness regarding that? So to what extent should it be replicated or not, identically or differently? just to inspire people, including myself, to get better data where we are.
I think kind of the methodology itself, it's, you know, a comparison between two groups and costs. It's easy to replicate in a way, but obviously a challenge obviously lies in finding the right data, that you need kind of relevant data and collect relevant data. So that's always going to be a challenge regardless of which country you're studying. But if you can find the right data, I think the short answer is yes, it should be replicated. You know, healthcare systems are different, and, you know, the kind of mechanics of how healthcare works is different. That may result in different costs. It can also kind of, if you see that, I don't know, UK, Germany, whatever, have come up with different costs, it may also be a debate like, okay, do they do anything differently? Could these differences not only be due to kind of design and data source, but do they actually do something differently, and open up that debate as well? So I think, and there's also things like that we haven't looked at, and the costs that we haven't included in this study, for instance, like institutional care and things like that. There's a lot of kind of self-management that's not picked up, and things like that as well. Family effects could also be another one, like the implications for the family. So there's also kind of things that we've not looked at that could be very interesting to get more data on. Audun?
Yes, I think one important thing is to have access to all the data that we had, and you have that in very many other countries. And what you really should try to do even better than we did is to get hold of the pain status repeatedly. So if you can follow a large group of subjects over years and see how their pain status and their disability status it develops over time, and that would give additional data to understand this group even better. And I would also like to say that ICD-11, I'm a strong believer in ICD-11. The good thing about ICD-11 is that it gives a correct, it gives a possibility to have a correct pain diagnosis. And I do not believe that in any countries ICD-11 pain will be implemented in all subjects. So but in the small group of really hard chronic pain, the ICD-11 can be used to learn more about specific pain subgroups, so that if you're interested in the healthcare costs and how rehabilitation and treatment can improve and reduce healthcare costs in subgroups, then ICD-11 could be used in those countries where you're now starting to collect that. And we started, in fact, before it was implemented. We started back in 2016 when it was only a pilot study. And I'm, as I said, it's easy to use in a pain clinic, and so the pain clinic should use that, and it gives them the opportunity to use other administrative data, to link other administrative data and find out more about the specific pain population that you are treating.
Thank you. Yeah.
We have a
Yeah,
couple of more questions. I don't know if you have seen them, Patrice.
yeah. If I can just insist on 2 words from Odin. So fluctuating conditions, pain and disability is not well captured currently. So longitudinal data, absolutely essential. And better data, or if people have access to data, yeah, that's definitely something extremely important. So if you have access to data, but not enough support to analyze them, there are many people, including Sept, but not only, but definitely happy to support. If I go, but happy to get some support from Joan and Odin, low to middle income groups, any policies? Yes and no. First of all, we need better data. That's an issue, because these groups probably need, in terms of equitable access to care, probably needs some processes, and that can be financial, but not necessarily only financial, but to compensate the disadvantage. They may also need something else than people with a different socioeconomic status. So that's a complex question, and I think mostly unaddressed, and partly because of not good enough data. So I do not know, Joan, if you want to expand on that, or then we know that there is something there. We may not know yet enough how to address that, even though clearly there is a group concentrating most of the issues and possibly having the biggest potential to get resources efficiently invested. What do you think?
Johan first, or
No, you
Johan?
go ahead first if you
Okay,
have any immediate thoughts.
I can give a comment as a clinician. You might not be aware that it was a Finnish study from the pain clinic back, I think it's 6, 7, 8 years ago, where they looked at the outcome after pain clinic treatment. And they did show that those who had low income or low education, they improved far less than those with high education and a better working situation. And more to translate that into a easy slogan, it's that we treat best those who are most like ourselves. So that means that well-educated people get the best pain service in the countries. And we should try to concentrate on these groups, blue collar work, because they might need more complex interventions, while those who have a high income job and are well educated, they might need a simple intervention and may support themselves further on and come back into job, while those with more physical job and far less paid job might need more interaction with employers and social support from society. So I think this is something we should concentrate on and try to have more individualized treatment that takes these things into consideration.
John, yeah. Otherwise, I have a comment for that, but yeah, please you first if you have.
Yeah, no, it's kind of building on what Odin just said. Like, it's not only about kind of the income levels itself. It's like, okay, but who are these people with low incomes and medium incomes and stuff like that? Like, they do have specific type of jobs that maybe they may have different reasons for the underlying reason for the chronic pain. They may also have different kind of immigrant status may also be different. So it's kind of that point of individualizing treatment, I guess, is very important, because those who are low to middle income, they have other characteristics than income as well, right? Like, there's a lot of different things behind that income measure that may explain why they are in the situation they are, and also respond in the way they will respond to any type of interventions. So income and it's just like a proxy for a lot of other things, right? It's not necessarily income itself that's the driver. It's what it represents and what's behind it. That's kind of the main thing.
Yeah, fully agree. Of course, for clinicians who are with us today, I'd just like to highlight two potential attitudes. One is an utilitarianist one, that may be to give up for these people. Just to say, like one of my colleagues told me, yeah, nothing work with these people. That's exactly what Odin said with this Finnish study. So we may then just give up and focus on people who are maybe the high responders because better equipped. Of course, the clinicians have not chosen that job not to take care of the most vulnerable, but that's why between the lines, mentioned, we may have to offer something different, which is aligned to Johan's comment. It's not just about money; it's about something else. And then even if we cannot neglect the financial aspect, but it's much more than that. So and that can be a nice balance also to try to reorganize our services, to think about what are the resources we have, what is to be invested in primary prevention, low risk individuals, maybe primary care, and what is the whole of more specialized care to address complex issues when it's still time to do something. And even if when chronic pain is installed, anyway, we have a role there to support these people, whatever their productivity may be or may not be. And we're also speaking about not working age people anyway, so it's not only about money, of course, but people from the economic and health economic world are definitely not saying that it's just about money. It's about how we use that money to create value, much more than about financial aspect only. So I think that is quite clear. But this double approach is probably good to develop and to invest, and for that, healthcare professionals have a role also. For the next question from Daniel Brom, I'm not sure if there are any Danish similar study.
I don't remember anything either, unless there's come out something very recently. There's Swedish studies I know on this, but if there's any Danish studies, I'm not sure actually.
Yes, some of the previous studies, they used diagnostic codes from the administrative system, and that's of course also is valuable, but they run into the problem that osteoarthritis need not be painful and so on, so that they have do not have the direct link to pain.
Yeah, so an important aspect, if in the future we can dream about implementation of ICD-11, of course, so then you're totally right. It's very challenging, and there is a big resistance to change. The WHO is really needing help. They're asking for help for implementing ICD-11, which is now explicitly, by the way, thanks to SIP's work, but explicitly mentioned in the European Health Data Space regulations, saying that the last version of the ICD is the one to be used. So that's good, but I fully agree that it will take a lot of time, and that will be probably a multi or complex process, addressing the implementation at different level and maybe at different time. It will be interesting in the future also to learn from successes and maybe from more disappointing or identified obstacles and challenges regarding that. But recognition of pain is an important aspect, independently and also when it's related to other conditions.
Can I also add another point there? I agree that ICD-11 would be is great, but that also means that you need to be in contact with the healthcare system, right, in order to get the diagnosis. And I think that's one of the benefits of the study we did. That's kind of a broad-based population study, so we go directly into the population and ask if they have pain or not. So a lot of these individuals that answer yes, they will be in contact with the healthcare system and potentially in the future get the ICD-11 code. But a lot of individuals may kind of self-manage as well, that also have implications. So they may kind of not work one day because X, Y, Z, and not report anything to the healthcare system and anything like that. So that's also an important part there.
Yes, so if you are a researcher having access to administrative systems so that you can see the costs from doctor visits and from hospital visits and from drug use and from sick leave, if you have that access to that, you may apply authorities and approach people and get the answers, detailed answers about things like pain, functional ability, quality of life. And you may do that repeatedly, and then you can give very valuable additional data. While ICD-11, as Johan said, that will be for a subgroup of those subjects who have disability due to pain. So that will be for our toughest or hardest pain patients, those who really have high disability and a lot of health care use.
Absolutely, absolutely. So my last message or my key home message is that we can definitely be stronger together. So feel free to get back to us. We're there to support the dynamic and to be sure that tomorrow can be brighter than yesterday.
Thank you so much. Thank you for Odin, Patrice, and Johan for today, your time, and congratulations on these wonderful researches. Thanks for the SIP to be introduced here. For our participants, I just want to repeat myself that you can have access for the article and for the SIP book in the invitation. You can find it in your email. Also, you can follow the EFIC YouTube channel where you can find other really interesting webinars. And you can have access to it. And as you can see it on Patrice's background, I think I would like you to be introduced with our academy system, what you can find in our EFIC platform. So thank you so much for today and for your time and for the wonderful presentations and the great discussion. Thank you, and have a nice day for everyone. Bye.
Thank you.
Thank
Bye.
you, Sophia.
Bye.